Department of Cardiology. Sir has been awarded Lifetime Achievement Award and Special Award in Cardiology. Sir has organized multiple national and international conferences, edited books, publications, and more than 800 lectures he has delivered. Over to Dr. P.C. Manoj.
So at the outset, I would like to thank Dr. Manoj Chawla, Purvi Chawla and his team for inviting me to this wonderful conference. Indeed, my great pleasure to be here. So for the next 18 to 20 minutes, I will be talking on from research to practice, the future of diabetocardiology. Medicine is essentially a resolution of uncertainty, and this has time and again been proved on several occasions, and it aptly applies to diabetocardiology. All of us has dreamt of gene therapy in past, and now genomics and molecular medicine has stepped down from the lab to patient care and is running the front race in current cardiac care and cardiodiabetology care, as I'll show you. All of us know glycemic control is an integral part of treatment of diabetes, and CGM has been a revolutionary step in this direction. But 70% of diabetics die because of acute myocardial infarction, and therefore if you want to increase the longevity of life of a diabetic patient, the attention has to be focused on acute myocardial infarction, and therefore save the heart should be the key step in the treatment of type 2 diabetes along with all other modalities of treatment. Now ASCVD, all of us know, is a multifactorial disease, but one of the major culprits for acute myocardial infarction is LDL cholesterol, and if you want yourself to be protected from acute myocardial infarction, the LDL lowering is a lifelong marathon that you have to clearly understand. You have to keep your LDL lower, what limit I'll be alluding to. We have data that if you want to arrest progression of atherosclerosis, the level is less than 70, data from the reversal trial, as you can see. If you want regression of atherosclerosis, LDL has to be less than 50. And therefore, if you continue to walk through this cardiovascular pathway with an LDL of less than 70 from early age, you will walk through it without any subclinical disease, without a myocardial infarction, and without any stent implantation, vast majority of the times. You have to remember that acute myocardial infarction only develops when the cumulative exposure of LDL to the arterial wall reaches the threshold of 7,000 milligram per year. So it is the cumulative exposure of LDL to the arterial wall which is of paramount importance in development. The earlier you achieve lower LDL and maintained it for a long time, more will be the benefits. So what are various options which are there? We have daily medications, we have bi-monthly medications, we have biannual medication, but the problem with all these medications is it is very difficult to have a good compliance. Suppose you ask an individual to take medicine for 10 years, 20, it's very difficult. But now gene therapy has provided us with a unique modality, once lifetime treatment. So the technique is CRISPR-Cas9 technology. Now this has two components, as you can see, a guiding RNA, which locates the specific genomic locus, which is PCSK9 in this context, and the Cas9 nuclease produces a double strand cut in the genome. So this you will see, now you will see that the guiding RNA will locate, this has located the PCSK9 gene, and the Cas9 has produced a double-stranded cut in the genome, and when it heals, as you will see, it produces loss of function mutation of PCSK9, and the individual becomes loss of function mutation, and the LDL drops to very low level for the rest of life. So this is a single-time treatment, and the Hard-Won trial in New Zealand are ongoing with this molecule, which is an intravenous infusion, VRV-101, and you can see if you used in the dose of 1.5 milligram per kilogram, the reduction in the level of PCSK9 level in the blood, normal being 35 to 25, is to the tune of 89%, and in LDL level at 68% for the rest of his life. So single-time treatment to lower LDL may in times to come, maybe the modality. You have to remember that if you want to win the battle against atherosclerosis, you have to directly hit at the plaque. No plaque, no atherosclerosis. And if you want to hit at the plaque, you have to have intensive lowering of LDL. It's not 10 milligram or 20 milligram. And you have to maintain your LDL at least less than 70, even for primary prevention. For the very high-risk patient, much lower. So gene editing is going to strip off the LDL villain. And we have published this article, Postponing Acute Myocardial Infarction for 100 Years, an Emerging Concept, in the World Journal of Cardiovascular Diseases last June 2024. And our great Bonwald also thinks in this direction. The other unresolved issue is that LPA-induced cardiovascular disease, we do not have any approved drug at the present state of time, and all of us know this is a deadly disease. How gene therapy is going to alter LPA? There are two ways in which LPA can be tackled by gene therapy. One is the ASO therapy, that is antisense oligonucleotide therapy, and the concept of this is when you inject drug which work on ASO like pelacarsen, it binds to the messenger RNA, destroys the messenger RNA, and therefore ApoA cannot be formed. Once ApoA cannot be formed, LPA will decrease. And this is pelacarsen is being introduced. It reaches the cytoplasm nucleus, combines with the messenger RNA. This duplex is cleaved by RNA, and messenger RNA is degraded, so ApoA cannot be formed. And the Horizon trial is ongoing, very likely to be released in early 2026. The other way is to utilize small interfering RNA. The principle of small interfering RNA is when you inject small interferon, it again combines with messenger RNA, cleaves it, and therefore the protein cannot be formed. And three small interfering RNAs, olpasiran, lepodisiran, and zerlezan, are in late stages of development. And we also have an oral molecule, mevalbucrin, which is undergoing phase 3 trial. And the beauty of these molecules is they lower LPA to the tune of 90%. LPA-driven cardiovascular disease is considered a slow death warrant because of premature development and malignant progression of ASCVD and currently lack of any approved therapy. But if pelacarsen and small interfering RNA, the trials come out to be positive, LPA-induced cardiovascular disease will become a salvageable disease in future, and this will kick off a new revolution or a new dawn of LPA therapeutics. And this vacant place, no drug approved for LPA, is likely to be filled in future with pelacarsen and other drugs. Today, only no drug is approved for LPA. Can mixed dyslipidemia be targeted by gene? Again, the answer is yes. Small interfering RNA targeting NPTL3, and this is the prolonged trial. You can see marked reduction in TG to the tune of 60% or so, marked reduction in VLDC, marked reduction in LDL and non-HDL cholesterol. And sometimes we do see patients of marked hypertriglyceridemia, and the solution to this is again antisense to ApoC, and you can see this is olezarsen, which has been approved by FDA after the BALANCE trial, 80 milligram once a month. The previous drug, voluntarsen, was not approved because of serious bleeding, but now we have this drug which lowers triglyceride by 43%, and you can use in these genetic hypertriglyceridemia. So time has come to rewrite the script of lipid management. If you review or if you read any script of lipid management, genetics is not there in the treatment of dyslipidemia, but a lot of advances, and therefore time has come to rewrite the script of lipid management. Unfortunately, if you develop acute myocardial infarction, we have a panoply of modalities to assess your coronary circulation and you treat atherosclerotic disease in the coronary arteries. Gene therapy is also advancing in the treatment of hypertension, and with gene therapy, blood pressure is taking a vacation. Why we are saying the single injection of zilebesiran, a GalNAc conjugated angiotensin and sirna, decreases the production of angiotensins, and with a single injection, your blood pressure can be controlled for the next 6 months. The other issue we have been hearing is obesity is rocking the entire world, running the front race in cardiometabolic diseases. And if the current trend continues, nearly 2 in 3 adults over 25 would be overweight or obese. We have lots of drugs you've already heard in the morning, but it is semaglutide and tirzepatide which is running the front race, and retatrutide is ongoing evaluation. But the big question is, do these drugs improve cardiometabolic outcome? The answer is a big yes, and this is the evidence from several trials in various subsets of atherosclerotic cardiovascular disease, CKD, OSA. So time has come to project the new face of obesity. What is it? Obesity is a disease. It's not only a disease, it's a new diabetes. If you treat obesity, diabetes would be minimized. And the other dicta is, with the new OAMs, treat obesity today with the new OAMs like semaglutide and tirzepatide, protect the heart, liver, kidney for tomorrow. And as you can see, the guidelines also, a fifth pillar is added by ADA, obesity management, which is very, very important, and all of us are discussing round the clock for this. Digital twin technology, I think, is again a great advance in the treatment of diabetes. Whole body twin technology for improving metabolism and remission or reversal. And this allows personalized and proactive diabetes management. Various metabolic parameters are detected, and with the help of an artificial intelligence and computer, a twin is created so that you can know this individual, what happens to his various metabolic when he takes food, when he takes exercise, and you can appropriately advise that patient. So with this twin technology, in the first 3 months, the blood sugars are normalized. Then in the next 3 to 6 months, healing chronic conditions like blood pressure, cholesterol, obesity, and improves organic health in the 6 to 9 months, and regeneration of beta cells in 9 to 12 months. And what is the data? Now, this is a 1-year outcome of digital twin technology for type 2 diabetes, a retrospective real-world study. You can see significant improvement in HbA1c after digital technology intervention. Improvement in CGM metrics, you can see the green line, tremendously improved. Significant reduction in the anti-diabetic medications, less anti-diabetic medications are taken by the patient. Digital twin technology is a big step in diabetes management and could play a vital role in the future of type 2 diabetes care. Gut microbiota and type 2 diabetes, again, gut microbiota are important in the pathogenesis. They produce microbial dysbiosis, they produce inflammation, insulin resistance, and work is in progress with fecal microbiota implantation, so that if this comes out to be positive, besides the conventional therapy of obesity, diabetes, bariatric procedures, and other drugs, this may become another modality of treatment. Regenerative and stem cell therapies in cardiovascular therapy. Now we are talking of heart failure. All of us know heart failure. Once sets in, it runs a malignant progression with a very high morbidity and mortality. The 5-year survival is to the tune of 50%. More diabetic die of heart failure than acute myocardial infarction. And the big problem with heart failure is drug therapy, device therapy, no doubts blunt this malignant progression, improves survival, but does not arrest, so that the end result is dismal. And therefore, cell therapy emerges as a very exciting option, but after several decades of research, we do not know if the beginning of end or end of the beginning, but research is ongoing, and in times there may be positive trials. Then we have a lot of innovative molecules, all of us are familiar, and SGLT2 is the molecule of the first quarter of the century, is a multi-saturated blockbuster drug. The beauty of this molecule, it can be used across the spectrum of heart failure, irrespective of the ejection fraction. Beta blocker stops benefit at 40%, RNA 55%, MRA 50 to 55%, and it slows down the trajectory of CKD and postponed dialysis about 10 to 15 years, and that's what we want. SGLT2 inhibitors continue to surprise us, and this time the surprise is given by a positive trial in valvular heart disease, patient of aortic stenosis, past history of left ventricle failure, undergoing TAVR. So in times to come, you will see SGLT2 inhibitors being used in valvular heart disease. So we continue to learn with SGLT2 inhibitors. CKD also previously we have 3 molecules which slows down the trajectory of CKD, RAS inhibitors, SGLT2, non-steroidal amylase that is finerenone, but now the flow trial with GLP receptor agonists has also come out to be positive. So now we have 4 pillars, but unfortunately CKD diagnosis is delayed vast majority of the time. The other important complication is MASLD. You can see normal liver and the fatty liver. And why we are so much interested in MASLD, most of the patients on MASLD die because of a cardiovascular event and not liver disease. Only a small number develop cirrhosis and liver cancer because MASLD is a gateway for cardiovascular disease. If you have MASLD, you will likely to have cardiovascular disease. In fact, it's a red flag for development of atherosclerotic cardiovascular disease. So you must utilize all preventive measures once you develop MASLD. But cardiologists, unfortunately, even cardiologists hardly paid any attention to it, although this is now being increasingly addressed. And we have this new drug, resmetirom, beside the old drugs which are useful, and this trial is positive. Resmetirom is likely to be introduced in India also by Lipid within a couple of months. The other advance which has occurred is that heart diagnostics have come on your screen, on your mobile, wearable digital technologies, devices. You can know multiple parameters in real time, blood pressure, glucose, weight, sleep, and so on, and you can act accordingly. Artificial intelligence is another new development and maybe the future of medicine. So you can have interpretation of electrocardiogram, echo, MRIs in a much better way, and it helps in several other ways, as you can see, because self is a separate chapter to be discussed. When we talk of type 1 diabetes, unlike type 2 diabetes, where remission is always a possibility, although may not be sustained, but cure of type 1 diabetes is still elusive, but slowing its progress is possible. All of us know immunotherapy with teplizumab can delay the onset of type 1 diabetes by 2 years or so, but beta cell replacement regeneration trials are ongoing. In times to come they may be positive, and gut microbiome is another area where research is continued unabated. And we have published this from research to practice in the Curious Journal. So progress never stops. Innovations in the cardiodiabetology continue and is likely to improve the outcome of patients. Thank you very much for your kind attention.
Inviting few questions. Manoria.
Sir, I would like to ask how low LDL should we target, or which should warrant a change or a reduction in dose of statins? Like, for example, if a patient achieves an LDL of say 20 or 15 on statin therapy, should we continue the same dose or reduce?
Yeah. You have to remember the basic concept that if you want to slow down the progress of atherosclerosis, it occurs at 70. Guidelines recommend primary prevention for an ordinary individual as 100 because there are no trials. But we have very clear data, so if you want to slow your progress, keep your LDL level not at 40, 45, because MI in Indian diabetic develops at 20 to 30, 30 to 40. From early age, I told you, LDL is a lifelong global pathway. So if you keep your LDL less than 70, you are very likely to free from cardiovascular event for next many, many years. If you have already suffered from myocardial infarction, you are late, but then the level has to be at least 50 because now you want your atherosclerosis to be regressed. The plaque which has produced myocardial infarction, which may be treated by the cardiologist, more myocardial infarction occurs from the non-culprit vessels. And when you take these drugs, it not only benefits the coronary territory, it benefits your brain territory, it also benefits because these drugs act across the atherosclerotic cardiovascular disease. But the earlier you better is the cumulative exposure, which is important. Suppose I start taking statins 30 years, 10 milligram will produce more benefit after 20, 30 years than an individual who start at the age of 35, 80 milligram atorvastatin. So cumulative exposure is very, very important. That is the crux of the prevention.
With the stem cell treatment advent, many things were found out. We thought it will be a very, very exciting field, but stem cell treatment never came up the way we were expecting it to be. Same thing applies to genetic treatment or genetic manipulation that we are talking about. Very often when we play with a sword, the wrong side of the sword hurts us. The point is that when we are giving all these drugs which are supposed to cause or bring about genetic mutation in the cells, they can go on the wrong path and actually cause more malignant cases or worsening of the cases. So do we have enough control studies, or are we taking that into consideration when we are actually when we are doing the trials? Of course, they have not come out as yet.
Genetic therapy has become a reality it is in practice. One example is inclisiran, which is a small interfering RNA we are using routinely. 8.7-year data is available without any side effects are restricted to mere injection. Pelacarsen is also being tried for last so many years, hardly produce any side effects besides an injection. A drug for olzasiran has already been approved by US FDA and will come in market. So many of these drugs are going to be marketed soon. Inclisiran is already available. Pelacarsen is also likely to be available in the next few years. And small interfering RNA. Most of these drugs have been studied for off-target effects for other side effects before these phase 3 trials have been conducted. So gene therapy is going, and what I was talking of, that LDL once in life trial is already in progress in New Zealand. So all these drugs, no significant side effects have been, no off-target side effects.
Then I will have no atherosclerosis at all once I take that injection.
Atherosclerosis, if you keep those patients who have loss of mutation of PCSK9, they live 80-90 years because the LDL is low since birth. So cumulative exposure is important. The earlier you lower your LDL, the better result. Suppose you start lowering at 30 years, the damage is already done. But you will benefit more if you start at 30 compared to another individual 40. So it's a lifelong pathway. LDL is not 1 day, 1 year, 2 year, 10 years. You have to have a lifelong lowering of LDL if you want to cross that highway without any atherosclerotic cardiovascular disease. So compliance is a big problem, and these genetic therapy compliance will not be a problem because once for lifetime, suppose this therapy comes in. Otherwise, you ask statin, take it for 5 years, half of the time you'll forget. How can you take for lifeline? Even with inclisiran, cost is a problem, 2 injections per year, but cost becomes a problem. Even if cost is not a problem.
With the interfering RNA treatment, very soon we will have medicine for cardiomyopathies also.
Small interfering RNA is not only in cardiology and is used in many other diseases also. So all these genetic therapies are going to become real realities. They are going to come in your practice. Some of the examples are already given.
Thank you, sir. Let's hope for the best.
I think that's the last question.